Okay, so the recording has started. So Carl, if you are ready, feel free to kick things off.
Thank you, Reagan. So my name is Carl Hinkson. I am the Adult Acute Section Chair, and today is March 18th, and this is a virtual meeting of the Adult Acute Care Section. I welcome everyone to joining this meeting. Today I am joined by one of the ICU RTs here at Providence and Everett, Daryl Kiefer. I asked him to join because he has been working a lot in our ICU recently during our COVID crisis. Daryl is also a recipient of the Phil Award, so he's a good guy, really smart, really experienced, but be kind because he's been working his tail off. He's worked 20 out of the last 24 days as we've all been working pretty hard out here in Washington State. You know, generally at the Providence system, we start our meetings off with a reflection, and I thought I would kick this one off. There is as I understand, a Chinese curse that says, "May you live in interesting times." In one of my more delusional times here in the past couple weeks, I looked up the source of that saying, and it's actually a misrepresentation. It refers to that if you know, life is good during peacetime and harmony, and life is very difficult in times of war and adversity. And so if you are living in interesting times, that means you are going through difficulties and adversity. And right now, I'd probably say this is one of the most challenging times in my career as a respiratory therapist and as a respiratory therapy leader, trying to make sure the staff feel safe, that they have the tools to do their jobs and to, you know, take care of the patient population. I'm going to give some updates on the section in general, and then we'll move on to talking about our COVID experience. The adult acute care section is one of the most robust. It's of the two, it's one of the largest. The only larger one is the neo-ped section by maybe a couple hundred members. And if you've missed it, the section bulletin is back. The next issue should come out in April. Karsten Roberts is the editor-in-chief, and he is making arrangements for articles to that. I'm very happy to be able to bring that back to the section members as a benefit. It was asked for, and look forward to seeing that. On AARC Connect, the section is one of the most robust. I have some data displayed for you up on the screen. There's a lot of posts, a lot of distinct posters, a lot of good topics and threads, and I think that one of the things I'm most pleased with as section chair is people will ask questions, and the section members feel enabled to ask questions, and other members go on there and answer those questions. We've had some pretty decent conversations, and it's a good source for getting information and seeing what other people in your community are doing. And I should note, I have to end this. I have a hard stop at 5 minutes till because I have to jump on another call. We are in the window to nominate the Specialty Practitioner of the Year. So any section member can nominate a fellow section member for the award. The only criteria is that both the nominee and the nominator must be section members. You can find the link to the nominations on the section page. The candidates will go to the AARC, and then after the nominations close on Monday, June 1st, they will collate that information and send it out as well. And then the chair selects the winner, which usually I will make up a small selection group of other recipients, and we will select the winner. So if you're considering nominating somebody as the Specialty Practitioner of the Year, please tell us why you think they deserve the award. I will tell you that in years past, it's become more challenging. I think last year there were 4 nominees, and I would have thought that every single one of them would have been worthy of the honor. but please, please submit your people that you really respect who work in adult acute care, critical care for this. After we select, I will give you a call to let you know that you are receiving the honor, and then you will be honored at the Congress in Orlando this year. So you'll get a nice round trip on the stage and some accolades. And it's one of the things, honors that I think you will be able to carry with you through your professional career. Okay, so any questions? If you type in the chat box about section questions, we can take those, but I'm thinking most people want to talk about COVID-19. So I will preface this with, I did not have a chance to really sit down and come up with a very outlined approach to talking about this, and what I typed up there was probably as far as I got. So I'm gonna, if I wander around on this topic, then I apologize. As you know, I work at Providence Regional Medical Center in Everett, and we were the facility that had the first identified patient with COVID-19 in late January, early April. Originally, when that patient arrived, that patient was not really sick. They just kind of had a bad flu, and they were treated by our BEST team, which is our kind of our special pathogens response team. So they took a very high level PPE and Ebola style track to him, and saw this patient in the special pathogen unit. And then I think the hubbub kind of quieted down. And then, you know, in Washington State, if you have a disease like Ebola, there are hospitals that are assessment centers that then transfer to treatment centers. And at the time, we were an assessment center, so if we got a very ill patient, they would be transferred to Seattle for a treatment. And from that first patient to, I would say, early February, late January, they downgraded the severity of COVID-19 to not requiring that special level of precaution. And we became a center that would have to treat COVID-19 patients. So it became a very significant reality that we would have to take care of these patients, because originally we thought if we got someone sick, we would have to and they got on the ventilator, we would have to transfer them down. And because of that thought process, we hadn't done a lot of extensive high-level PPE training. And so once I found out, I had to talk to the staff and inform them that, you know, it was a very real possibility that we could be taking care of patients with COVID-19 on ventilators and in ICU and various places, and that we needed to start doing aggressive PPE training. The team was very resilient and took to the training with no problem. I think the just-in-time training worked. I would have always liked to have more lead time to prepare people, but I'm going to give a shout out to Daryl here, because he was with me when I announced to the staff and that we would be taking care of these patients. And he was very calm, cool, and collected, and he kind of informed the new therapist that we got this. And so we kind of braced for it, and then we started seeing patients with COVID, rule out COVID, and then started seeing active COVID. One of the real problems that we've had out here in Washington is, and you may have seen in the media, is the turnaround time on test results. So I think, you know, it's all kind of blurry, but for the initial week or so, I think, no, I told you guys on it was Thursday. Okay, this escalated rapidly. So on Thursday, the RT staff and the nursing staff started doing PPE training in anticipation of a couple of patients. By that weekend, my wife, who is a nursing educator, who is a med-surg educator, was called at home at 2 in the afternoon to begin PPE training for floor staff. She did not return home until 8 the next morning. And then the training was going on quite a bit. And we have seen a significant surge in patients. And when I say significant surge in patients, our volumes are increasing steadily, 30 patients either rule in or rule out each day. It initially started on, our hospital has sort of a shoehorn architecture, and we started on our top floor because that's, from the engineering perspective, those were all our negative flow rooms. So we started up there, and then it spread into, for what we call 10 North or 10 South, it spread into 10 North, and then MICU. And I'd say by now, that was one floor. Now we're on 3 floors, and we have it all over. We have patients located all over the hospital. At one point, we had a total of 100 patients that were rule in or rule out COVID. So it has really taken over the hospital. I signed up for hospital incident commander as we follow the HICS structure. HICS is the Health Center Incident Command structure that is sort of laid out by the government. I took 2 days of incident command over a weekend, and it was kind of a great learning experience, but it was also rough from that perspective, as we were just very busy. And where are we at now? So we have, I'm really not at liberty to say how many positive patients we have, but we have quite a few positive patients on ventilators in the ICU. We have quite a few patients awaiting rule-out tests, quite a few positive and rule-out patients on the acute care floors. It has impacted hospital operations to such a degree that we have stopped elective procedures. We have closed the entrances to the hospital. They are all manned, and you have to have a temperature check upon arrival. And every employee has to monitor themselves for symptoms every day. So I and Daryl I have a thermometer in my office, and everyone else has to do an attestation. From the respiratory therapy side, a lot of the work has been in the ICU. Do you want to talk about it?
Yeah, it's
Scoot up there.
So it started a little over almost 2 weeks ago. We were almost 2 weeks out. We started with just a couple rule outs, and then we had a patient who was a rule out whose wife had tested positive, and we decided to rule him in without the rule in. So we treated him like he was positive, and we ended up getting the test back, and it was positive. What we've been finding with these patients that have COVID that are starting to go bad, they go bad quick. We are going from a non-rebreather to intubation almost immediately once they start to decompensate, and they decompensate fairly quickly. We're trying not to bag them as we go, and our first patient, within a day, he was on 90% and 18 of PEEP, and his X-ray chest is the weird part about these patients, and this patient in particular, is that he looked very artsy. You look at the X-ray, it was a complete whiteout, but his lung pressures weren't showing that. Our plateaus and our peaks were low 30s on the peaks, mid 20s on the plateaus, and for somebody who was on 18 of PEEP, we were kind of surprised by that. I just recently was able to liberate that patient from the ventilator today, and he's doing okay right now, but it's been a long road. He's almost 2 weeks out now. We have another one, the second patient, who is not far behind him, and we're at the point where he's on an SBT now. He's hanging in very well. And just be cognizant when you do get these patients, they're going to go bad, and they're going to go bad quickly. And it's a very quick turnaround on them.
So I see on, I'm going to interject here. I see on the discussion boards, there's a lot of questions about high flow nasal cannulas and non-invasive. Our early experience is showing that if you try to use these bridge therapies, you're delaying, you're just delaying it. And we've had a couple instances where we've placed somebody on a high flow nasal cannula, tried to place them on a acute care floor, and they're hardly hitting the door, and then we have to transfer them back to, or transfer them to the ICU. So you know, part of it is there is increased risk for cross-contamination, and I know that that's an ongoing debate, and I've received letters from you know, the companies, some devices saying that the risk isn't that bad, but clinically, from a clinical standpoint, if they have acute respiratory failure related to COVID, the bridging therapies just are not that effective. And I think I also want to kind of point out that the older patients, this is not really impacting younger patients. Most of the patients are in their 60s or older. I think I was looking through the list this morning. The youngest patient I saw was maybe 60 that was intubated. 38, Daryl is saying. There is one in the community, I guess, that is in their 40s that is on ECMO, and that's, as far as I know, the only COVID patient that's been placed on ECMO. But definitely is hitting the older population more prominently. I've been in touch with my colleagues at the Children's Hospital, and they are not seeing the volumes that we are. We've proned a couple of patients.
We attempted to prone a patient, and it didn't go well, and that is the patient that we just actually extubated. We have not proned anybody yet, and it was mainly, a lot of it had to do with staff, because we were just getting inundated. So we haven't got to the prone portion.
Prone portion.
Yeah.
So I know somebody reached out to me and asked me about ECMO for these patients, and we don't do ECMO here, and so we would refer them out. I checked around with the centers that are doing ECMO, and as far as I am aware of, there is only one patient that is receiving ECMO related to COVID. The system is kind of stressed right now out here. Our biggest challenges are PPE, supply chain with PPE. So for those of you who are bracing for this, I would be very conservative in usage of any PPE, even prophylactically. I think I saw somebody post that their hospital was requiring them to all wear masks. And my concern with that approach is that you are burning through your supply before you really need it. We need to be conserving the supply for the direct frontline caregivers and trying to triage it there. We are steadily seeing increases in ventilator patient population. So we're a facility, we own around 40-ish vents, I will say, and we have 26 vents running, and we've been seeing that number steadily increase. So my goal for today is to try and find more ventilators. And as soon as this happened, the rental company sucked up all the vents in the community, or everyone sucked up what was rented out in the community. So everyone's kind of scrambling, and I and the ICU docs are going to try and create a mitigation plan. So for PPE, if they are in, if it is rule out, then we follow droplet precautions, except for when we're doing any aerosolized procedures. And then we could follow airborne precautions, which is a capper or an N95. In our medical ICU, we are, sorry, distracted. In our medical ICU, everyone is airborne precautions. There is a question, are we requiring staff to change disposable masks between patients? Or are we trying to use the same mask? For N95, we have a process for using the same mask all day. You have to cover them, you have to inspect the mask for, visual tears, and then you wear a regular surgical mask over it. I think regular surgical masks are still one-time use. So I'm going to close down this presentation and see if there's the chat box up. And I think if anyone has any, let's see, there's chat. There we go. All right. And try and answer some questions. So I'm going to start at the top. What's the normal bed count for Providence? So Providence is split into 2 campuses. I can give you the exact information from this morning's bed page. So at Colby, which is our main campus, adult campus, we are at 459 beds total, and this morning we are occupied at 404. Our ICU and medical ICU and surgical ICU are almost completely full. We have been trying to selectively target these patients into specific areas for conserving PPE. And every time we move to a new area, we create a headache because now we then have to do just-in-time training with that staff. We also have to relocate PPE to that area, so you can no longer cohort PPE. And if you put somebody out in a new floor and you give them nebulizers, that places them in airborne precautions, which means you have to provide a capper and a N95, because not everyone can wear N95s. They can't wear an N95, then they have to have a capper. How high are you going on liter flow on the non-rebreather prior to intubation?
We're going 15 and greater, making sure that that bag stays inflated, trying to oxygenate them as much as possible. We're finding that when they get to the point that we're intubating them, they have like 0 reserve, to the point where I intubated somebody, took the non-rebreather mask off. Before I got the laryngoscope in his mouth, he was down into the 70s, and then it took a while to recover. So we're trying to give them as much oxygen without mask bagging the patient. We're going right to intubation and then hooking them right up to the ventilator.
Do the peak airway pressures ever go over the 20s?
They've been in the 20s. We're seeing typical pressures in the high 20s, low 30s. Say for one patient who she's on 6 mils per kilo and her peak pressure is around 33, 34.
Do we have any peds patient? We have maybe had a rule out or 2 of pediatric patients. We have not, I think we admitted a rule out, and then I think they ruled out. I'm not positive on that. We have not, generally, we have not seen the pediatric volumes in any way, shape, or form that we've seen this hit the adult population, the adult senior citizen population. Next question from Tracy Roberts. How are you managing or anticipating who gets ICU level vents versus other lesser ventilators? That will be managed with the ICU directors. That's part of my goal today, is to try and make those decisions, or have a plan for mitigation, is understanding who has what ventilators do we have in the community, and how are we going to decide who gets what. But I don't have a firm answer on that. I know that of course, we're going to try and keep the, our main ventilator fleet, our draggers, try and preserve those for our sicker patients. We have some LTVs and some Zoll ventilators. and we'll probably reserve those for those patients who are less sick. And then we are acquiring some disaster ventilators that are very basic, scaled down, and those will do rate and tidal volume off of an oxygen source gas, and we'll figure out how we're going to do that. Interestingly enough, as we've shut down all our procedures, we have begun exploring how we might be able to use the anesthesia machines as ventilators. That is not something, a topic I've been able to work through, but that again is on my to-do list. I know it will be kind of a change, and we'll have to think about how the anesthesia machines are different, but they're really not in use right now, and so that's another option for us. From Christopher Martin, has airway mucus clearance been an issue?
I've not really seen much of an issue with mucus clearance or airway clearance. It's mostly just been an oxygenation issue, but not a secretion issue.
From Jessica Dietz, were you following ARDSnet? Yes, we follow ARDSnet. We do 6 liters or 6 milliliters.
6 mils per kilo, and we've had to go down to 4 mils per kilo on one patient, and that has since turned around on that patient.
Thank you. Do you give non-ICU patients NEB treatments or MDIs? We are preferentially giving MDIs to COVID patients because if we're giving NEBs, we're making the rooms airborne precautions. And it's been a real headache to try and manage how long before or after a treatment the room has to be an airborne. So if they're receiving NEBs, the nursing supervisors are just making the rooms airborne precautions. So what we have done is we've tried to convert all these patients to MDIs. Now that has created a secondary impact, is now that we are seeing a shortage of albuterol MDIs. And pharmacy is asking that we establish a response, we see a response to the bronchodilator with a nebulizer before giving the patient an MDI, because now we're running short on albuterol MDIs. So, there may be a good thing is that we actually will have to establish need for a bronchodilator before giving it, which is, new for some people. As I like to say, albuterol is made from the tears of Chuck Norris, and that's why it cures everything. Are Vortrans in our ventilator supply chain? No, they are not. Vent availability, has there been any activation of the Strategic National Vent Reserves? I do not know the answer to that question. I have asked that question, and our system people are working on that. So, the way that the structure is working is I'm working in, Daryl was working in the ICU. I'm working in leadership, trying to make sure staff and stuff is available. And then we have system people that are looking at the larger supply chain management issue. And I do not know where the National Stockpile Reserve is at this point. Andy Mulva, oh, sorry if I mispronounced that. How are you filtering vent patients?
We have gone to dry circuits, and we're using HMEs at the patient Y with HEPA filters at the exhalation port.
What have you done post-extubation? Non-invasive?
So we're trying to keep these patients off of non-invasive or high flow. We're trying to limit the possibility of aerosolizing anything more than we have to. And today was the first post-extubation, and we extubated him right to a non-rebreather mask.
Are you using an additional expiratory filter on the expiratory limb?
We are not. We're just using the HEPA filter on the expiratory limb.
From Kimber Catalulo, do most patients intubated have underlying conditions, asthma, pregnancy, or just age? Yes, they often all have some underlying issue. There's even I think I was reviewing the medical records, even some of the younger people who were intubated for flu have some underlying condition. I think there was only one that I read that was previously healthy. But for the most part, these are older folks with comorbid conditions. What modes have been used? How should a small department mitigate using advanced ventilation skills with minimal experience with managing ARDS?
We've basically gotten away with assist control mode. I had a patient that he was actually starting to pull tidal volumes over what the vent was wanting, so we switched him over to pressure control, and that worked very well. But it's going to be what the doctor is going to feel comfortable with and what the RT is going to feel comfortable with is basically how we've been rolling.
I think we've been just rolling with a lung protective ventilation LPV ARDSNet style protocol, and that should be able, even small facilities should be able to do this. We've not been going off the reservation too much, so to speak. Heather McKay, do you allow your therapists that work with COVID-19 patients to work with regular patients on floor in ICU? So that's a great question. I think originally there was a thought process from hospital leadership that if you were working with COVID patients, you should not be working with other patients to decrease the possibility of cross-contamination. The problem that we had with that is that was not a sustainable model as the volume of patients began to increase. So now we've kind of established that as long as you follow proper PPE, you can go in and out of any room. And I don't think we have any documented issues of cross-contamination. We're just burning through a lot of PPE. From another question from Kimber, what have the compliances on patients been?
The compliance has been actually, pretty, they're very compliant. That's the part that's kind of been a little bit of a shock to us, is we're not seeing any compliance issues with these patients.
Have we been using APRV?
We have not been using APRV, and again, that just goes to comfort level of physicians, what they're used to using and what the staff is comfortable using right now. We've been going off the ARDSNet protocol and pretty much sticking with
that. What residual effects are you seeing from patients extubated, oxygen requirements or need for bronchodilators?
Since we've only really had that one patient, the issue that I've seeing is just the weakness of being intubated for 2 weeks and working with that patient. I haven't seen any needs for bronchodilators. Breath sounds have been fairly clear, other than some of the coarse rhonchi from having that tube in, but the weakness from being intubated is the main issue.
Question from Vince Longbucko, are you trying to intubate patients I think the question is, are you waiting till we get to the ICU to intubate patients? We've intubated at least one patient in the ER. If they're on the floor, we try to get them to the ICU before we intubate. And again, this comes back to a matter of, your stuff that you have in the room and the amount of PPE it would take to intubate somebody. So I think, the ICU is the best place because that's where right now the PPE is most readily available. But we do have PPE in our ER, and we did sort of dedicate one section of our ER for these respiratory rule-outs. Christopher Price is asking us to repeat the filter.
So the filter thing, so basically we've been going with a dry circuit, not using humidity to try and cut down on aerosolizing anything that we can. And we're going with HMEs on the patient Y and HEPA filter on the expiratory line.
Are we concerned about changing HMEs with dry circuits?
We are concerned with changing HMEs on dry circuits, but less concerned about that than we were concerned with changing the wet HEP filters, because that was on a more regular basis.
Oh, what is the average number of vent days on this group of patients? It's been long.
The patient that I extubated today was on day 16.
They're going on and staying on. They're not really coming off. Thoughts about APRV? I think we answered that one. Our medical intensivists are comfortable with lung protective ventilation. They don't regularly use APRV, and we haven't felt a need to go off the ARGNet protocol. Teresa Balt, what are you using to establish a broncho response? We have considered establish pre-use criteria, but peak flow seems it would be considered aerosol generating. So far I think we're just using clinical assessment. We haven't gotten as far as to whether or not we would use a peak flow or not. I am not certain. I would consider doing a peak flow maneuver in aerosol generating procedure, but I would have to think about that more.
What we're seeing in these patients is patients who are in severe respiratory distress. There's no way you're going to get them to do a peak flow maneuver, and when you see them, you will know. We're going right from non-rebreather to intubating. There's no chance in getting a peak flow from these patients.
Christopher Price, PRVC for these patients or start a control mode? We've been starting on assist control.
We've been starting on assist control, and I switched one patient over to PRVC, and he did very well with it.
Michelle England, can you restate the type of circuit you are using, humidified or HME only? We are using HME only right now. James Gonzalez, to everyone, how are ER docs using comorbidities to differentiate COVID? This is being recorded, so I will be as PC as possible. So they are going with an approach, if they have a high level of suspicion of COVID, they go down a COVID road. If they have a low level of suspicion of COVID, then they will treat it as though it's a comorbidity. For example, we had a gentleman that was having a COPD exacerbation with a high CO2, and the ED physician felt it was a COPD exacerbation more predominantly versus a COVID acute respiratory failure. Ordered non-invasive ventilation, and the therapists used their safety tools to clarify, and we placed the patient on non-invasive ventilation and then later wound up intubating the patient. So they are still kind of following their clinical thinking on this. I hope that answers your question. Stephanie Kinney asks, are you donning your rule out COVID-19 in a separate area? We have created a doffing area. We put some tape down on the floor because that always makes it better. In front of the room, out of the room, and that's where they're doing their donning and doffing. Are you rooming your rule out COVID-19 patients in a separate area? All our COVID-19, we are trying to keep the rule-ins on one area and the rule-outs in another area. So if they rule out, then we can move them to a regular part of the floor. If they rule in, we kind of move them to with the rest of the positive patients. So we've kind of taken over at least one wing of the hospital and a good section of our ICU.
Just know that that doesn't always work out as planned.
Exactly. And since this is being recorded, that's all I'm going to say. What is your average vent days on survivors? We've only extubated one so far, and that was today. Let me find where I was at. Stefan from again, sorry again if I mispronounced your name. If the compliances are actually not bad on these patients, what is the most significant deficiency in the respiratory system? I would say it's a diffusion deficit created by the pneumonia. So their compliance is decent, but there's poor gas exchange. Shannon Fletcher, what is the mortality rate for your intubated, ventilated COVID-19 patients? I don't really have a specific number. You know, as this is new and evolving, any number I gave you would be different next week as we get more and more patients, more experience. I would say if you get intubated for COVID, your mortality is pretty high. Are we clamping ET tubes when disconnecting? No, we are not. We are trying to minimize the times we disconnect, which was one of the main reasons we went to the HMEs. How often should HEPA filters be changed? Every shift or once a day? Any problems with increased resistance on Draeger vents using a HEPA filter?
Have not seen any difference in the resistance with the HEPA filters. We're trying to minimize changing them out because we want to make sure we have plenty of supply for what is coming.
And I should add that one of the HEPA filter supply issues was when this surge began happening, our anesthesia colleagues decided that they wanted to HEPA filter all their procedures. From the design of an anesthesia ventilator, an anesthesia machine, if we potentially ventilate a COVID patient and then it's not known, that takes that anesthesia machine out while some of the internal pieces have to be removed and sterilized. So they started using HEPA filters for all their procedures, and their first source of HEPA filters was actually us. But you know, that supply issue may have changed since they stopped doing any elective procedures. Where am I at? Is oxygenation really the main issue? It doesn't sound like. Ventilation is the issue. If compliance is relatively normal. What do gases look like?
The main issue with the gases are we've been having really low P to F ratios, which increases the patient's work of breathing, and that has been the main issue. Ventilation issue, we've had a couple of problems with some of the ventilated patients, but those are ones that have had other comorbidities.
From Randall Knapp, have you had to quarantine staff? So the way that works here right now is if you have any symptoms, if you have a fever, cough, shortness of breath, I forget the other one. Anyways, temperature, you have to call caregiver health, and they will tell you whether or not you can come at, you have to go home or not. In Washington State right now, we are sort of self-quarantining. We're sheltering in as it is. So, you know, traffic, which is really usually pretty horrendous, is pretty good right now. We're pretty much the only ones coming into work. Everyone else is staying home. I have not had any respiratory therapist test positive for COVID. Their caregiver health is quarantine. I don't want to say quarantining. They're putting people at home and making them stay home and kind of managing it from there. So our employee health department is very busy right now. And I should also add that we seem to have a regular flu going through the staff. So that has sort of compounded some of the issues. Genevieve Barrett asks, are you using filtered small volume nebulizers? If given, we are using band nebulizers. We have not been filtering them because we're in airborne precautions, but we're using band nebulizers to minimize any room aerosolization. Ann Snyder asks, what have chest x-rays typically been showing?
Basically, the chest x-rays have been whiteouts, typically seen with ARDS patients. If you're familiar with looking at an ARDS patient x-ray, that's exactly what they've been looking at. I've been looking at, and that's the part that's surprising with the patient compliances.
Okay, and I think we've run out of questions. Can patients test positive for flu and COVID-19? I don't believe so. Yeah, Daryl's got to go. So thank you, Daryl, for your time.
Thank you.
So I don't believe so. So our process has been, we test them first for flu, and if they are negative for flu, then we move on to testing for COVID. I've not heard of anyone testing positive for both. Have there been any false negatives? Not that I'm aware of. And anyone that has been inconclusive, we have treated as positive. I think I went out of order. How big is your RT staff? We have about 75 therapists working at 2 campuses. Our other campus is predominantly mother-baby, and so we typically staff between about 6 to 10 therapists on this campus, 2 over there, and we've been running full bore. Heather McKay, any words of wisdom to those that are just starting to see these patients? My words of wisdom are be very proactive in conserving your PPE. Be very proactive in establishing your PPE protocols. Make sure you get enough rest. That's been when Daryl has been working a lot. I've been working a lot. My staff has been crushing it, but they've been working very hard, and we're encouraging people to make sure that they take their time off. We don't know if we're still on the upward trend or if this is going to taper off anytime soon. Any secondary bacterial insults? Not that I've seen or heard of, but that is very much a potential for those patients. How's our event to RT ratio been? What's your max capacity? We typically will try to keep it to 5 vents to RT. It's been a little bit rougher because the amount of time it takes to don and doff. I think initially we were even getting away with 1 RT to 1 or 2 vents, but we're kind of back to, if I did the math, it's probably about a 1-to-5 ratio today. Our max capacity is determined by how many ventilators I can get my hands on and how many staff that I can get in. We are doing traveler contracts, and we're getting staff that we can get in as fast as we can. So from Stefan Frimbigen, what would you say is the most important training that RTs are not usually working with high-level ICU patients should get? I think you should make sure you're good on your PPE, evaluate, making sure that you are comfortable managing patients at least minimally according to the ARDSNet protocol, and that you're familiar with the modalities and nebulization and getting MDIs. This is, aside from the infectious disease process, these are bad ARDS patients. Michael says, stay safe. I'm trying to. Are we reusing N95 masks? We are not reusing N95 masks. We are, well, it depends on how you define reuse. We will reuse them in between patients. If they cover the N95 mask, with another surgical mask, we will use it up to a day. The CDC put out some guidelines which you may follow. And, you know, I've got maybe another 3 minutes here before I have to jump elsewhere. And what I will say, one of my, you know, experiences has been, we're very busy. We're kind of solving problems for the next hour and the next hour and the next day. So it's very hard to read information that is published by WHO and CDC. So we're relying on other people to inform us. So I've been very heavily reliant on my infection prevention people finding out the information, disseminating to us, and then I try to disseminate it to the staff. It has been a bit of a challenge, I will admit, trying to keep everyone up on the information because it changes so frequently. We've had changes that were so frequent that if I took, you know, I took a weekend off and I'd come back and something would be very different. And so it's been very difficult to keep up on the changes and to communicate that to staff. So a lot of mental flexibility and resilience is required. All right, I appreciate everyone who's jumped in to join. I hope that you found this informative, and you know, God bless and stay resilient out there. This is what we do. This is the time for us to prove our worth to the community and to the world that respiratory therapy rocks, and stay safe. With that, I'm going to sign off.
Thanks a lot, Carl. Appreciate it.